You know, does BCG disease belong to TB specialists or to infectious disease specialists, or really nobody knows how to manage this unless they've seen a couple of cases? This cartoon here, just in case you're curious, this is a Eurasian badger who has commenting on whether or not his friend has died of suspected Mycobacterium bovis infection. Obviously, Mycobacterium bovis is the progenitor of BCG, and badgers in England are still a major concern in terms of whether or not they're causing transmission of M. bovis in the cattle herds over there, and there's a lot of controversy about what to do about the badgers who have M. bovis infection. So back to who owns BCG disease. Patients with BCG often present to TB programs because their cultures are initially identified as MTB complex if they grow something. However, they don't count, and someone can correct me if I'm wrong, they don't count as TB cases when we do our case counts. And BCG, when the strains are molecularly identified, can be clearly identified as BCG by its molecular fingerprinting. Some of these cases end up being treated by local TB programs. I know we have treated several of those in our TB clinic, but there are other TB programs that say, well, this isn't TB disease and we don't need to be involved. They may have a pulmonary component to their infection, but they don't generally present as primary pulmonary disease, and it's not considered a public health menace because the transmission, it's not felt to be respiratorily transmissible in general, although there are some concerns about transmission of BCG. But it doesn't matter who it presents to because there's not a lot of expertise and even consensus guidelines for how to treat disseminated BCG disease because it's still a pretty rare entity. I think so. This brings us to a little further in our patient's course. At the time of our first discussion, we really did not have any other diagnostic tools to offer other than the expectation that there was a good likelihood that this patient would grow mycobacterial organisms in blood. But I don't think that there is any specific testing that you can do for BCG disease, and we'll talk about the fact that many of these patients don't even grow BCG from cultures when these syndromes are identified. So before we move on to the next phone call, any comments or questions? Okay. So the second call occurred about 3 weeks into the patient's hospital course, and at this point, the patient had actually survived his initial acute illness and was improving overall in the intensive care unit. At this point, he was off of pressors. His renal function was improving a little bit. His transaminases had improved, but his bilirubin remained elevated. He was found to have heparin-induced thrombocytopenia as the explanation for his thrombocytopenia and was being treated for that. It was not felt to be medication-related. And at this point, his BCG regimen continued to consist of rifampin, levofloxacin, and ethambutol. He remains on corticosteroids. At this point, I think he was still receiving parenteral salumedrol, and he was still intermittently febrile. So sort of the questions that are posed here are, okay, we're now past his acute illness. He's about 3 weeks in. Do we continue his steroids or not? And what do we think about his current BCG regimen? And should he